Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Chris Apfel. He is a physician and clinical researcher. Today's Kevin MD article is Functional Precision Oncology, a game changer in cancer therapy. Chris, welcome to the show.
Thank you very much for having me.
All right. So before talking about your article, just briefly share your story and journey.
Okay. As you may have already recognized from my accent, I was made in Germany over half a century ago, done a lot of clinical work, done a lot of research to see how can we really improve patient outcomes. And so did a lot of research that published over 100 papers, published at some point a paper in the New England Journal of Medicine, had a nice offer at the Cleveland Clinic, had an offer at Harvard and Stanford, and decided to go to UCSF, University of California, San Francisco. And continued with my research until my dad was diagnosed with lung cancer. I got a call in the morning, Monday morning, and apparently he had stage 4 lung cancer. I was not aware of that. I asked my oncologist, what should we do? Because I was on the cancer IRB at the University of California. And he said, well, he probably needs cisplatin paclitaxel. And I said, well, he may refuse. What's the evidence that this works? Because when he took care of my mother who had ovarian cancer, and the treatment didn't work in her last months of life and made her only more miserable, he said, unless you can promise me this is going to work, I don't want it. And that's actually what happened. And I said, well, wait a minute. I thought the future is here now. I thought we are all talking about precision medicine. I thought that we have it all under control. Can't we do genomic sequencing? Yes, we can. But only 1 out of 4 patients have actionable mutations. And that's actually where the story started, where I said, the public doesn't know that when a tissue is examined, a biopsy is done, you do histology or pathology is kind of better understood in layman's terms. And you try to classify the tumor to get an understanding what could or what could not work. And it's based on number of many studies that really compare groups of patients, but every patient is different. And that's actually where the journey started.
All right, excellent. So tell us how that leads into your Kevin MD article, Functional Precision Oncology, a game changer in cancer therapy.
Yes. So with the recognition that if we just look at the genome, we are only looking at a very small snippet of the cancer biology. And the cancer biology is not driven by a single mutation. The cancer biology is much more complex. And the best way, as I'm also an adjunct professor of biostatistics and epidemiology, and I love clinical trial design, the best way to predict the future is actually to create it. So I said to my oncologist, so why can we not take the tissue, put it ex vivo in the lab, put different drugs on it, to see which of the treatment options is really best for that individual patient. And this idea is not new. And it's actually, I only came on this because in the ICU, when I've been treating patients with sepsis, you always do an antibiotic sensitivity testing. You always want to know which antibiotic works best. And it's the same principle. And why should this not work? This is biologically, medically plausible, right? And the answer I got is, yeah, people have tried this before, but it never worked. And I said, that's odd. So I looked into this, spent about a year to really review all the data that has been done. And there have been done data back until the 80s. And it turns out that you can actually double the patient's chance of a tumor response if you know ahead of time which therapy is most likely to work. That's a big deal. That's a bigger deal than any drug that's in development. And yet, it's not standard of care. And there were a number of reasons for this, why this is not standard of care. And one of this was the early phases, they were trying to grow tumors. And if you have an aggressively growing tumor, you can do that, and you can compare how you can slow down the tumor growth. The problem is, it takes months to grow the tumors, and by that time, the disease has progressed in the patient. So by such a clonogenic assay, it's hard to really make a difference to patients. And then if you have the other extreme, when the tumor is a slow-growing tumor, low-grade tumors, they sometimes grow very slowly. You can't grow them at all. You don't have a test result then. So we do know that in principle, the biology, you can replicate it ex vivo, and it correlates with patient outcomes. But if you try to grow tumors, it comes too late to really have a clinical impact. Now, there has been a lot of NIH research on organoids, and there has been a lot of progress being done. But all these academic spin-outs that are based on NIH-based research, they don't really have the impact for patients. The way was, and that's actually very interesting, Larry Wiesenthal, Robert Nagurney, they started off saying, well, we need to actually to see whether we can kill the tumor. And so they developed a technology, the disk assay, where they could actually, within a week or 10 days, actually see whether they can kill the tumor. And they did a lot of studies on this and were actually able to show it, and were actually active in the 90s until the 2000s. And then what actually then happened was genomic testing came along. And genomic testing is interesting because it's mechanistically plausible, it's fascinating. It's been developed as a companion diagnostic. So the FDA approval of a drug is dependent on the mutation you have. And suddenly, Big Pharma was highly dependent on, because it was harder and harder to develop a drug that can work on a patient population. Genomic testing was kind of the ideal tool for drug development to better identify patients who would benefit from a targeted therapy. And so the FDA approval, and with that, reimbursement was tied to genomic testing. And that's actually why genomic testing took off. And that's also why functional testing has fallen on the wayside. But what's interesting is that now people are more and more recognizing the limitations of that. I mentioned the National Cancer Institute's MATCH trial that Keith Flaherty from Harvard published a couple of years ago, where they looked at actionable mutations of over 5,000 patients, I believe. And they could find that only in 1 out of 4 patients, you can match it to a target therapy. And to everybody else, it's basically still a hit or miss or trial and error.
Let me just jump in here and just give us kind of a case study. Give us, so that way we can, for the physicians who'll be listening, what will be an example of a specific cancer, a case study that really kind of illustrates this functional precision oncology approach that we're talking about today.
Yes. And at Sage, what we have developed is a technique where we can actually create hundreds of 3D microtumors that reflect the tumor heterogeneity and variability within each of the valves. And we can create those within 1 day through disaggregation and reaggregation. Then we drug them over a week, roughly a week. And then we ask them how they feel about it, whether they are completely drunk or whether they are not affected at all. And what we can see is we had, for example, an ovarian cancer patient who has failed first-line treatment, second-line treatment, has failed carboplatin paclitaxel, has failed PARP inhibitors, and is really progressing. And so we were testing a wide range. We got the sample shipped overnight. We were testing a wide range of drugs. And we also tested, interestingly, VAC, which is a combination, vincristine, actinomycin, and cyclophosphamide. So we're testing this, and it showed great effectiveness. And the reason why we tested this was in the NCCN guidelines as a salvage therapy. It's rarely given. But interestingly, a week later, the histology report came back and was actually showing, this patient's tumor had sarcomatoid components. And VAC is a typical combination therapy for sarcoma. And it's very interesting. And so that's a nice success. The other part is, and a lady out of San Diego presents, a music teacher, presents with an ascites. And ascites is not a good sign at the early stage, at the initial stage. And interestingly, so we tested out of the ascites, out of the paracentesis, we were able to get tons of tissue, so no extra biopsy needed, no extra surgery needed. And it was highly sensitive to the standard therapy, carboplatin paclitaxel. She got this as neoadjuvant therapy, responding beautifully. But we also saw that because our test can actually test both cytotoxicity and antiproliferation, we also saw that there is a subset of tumors that is likely resistant to it, that is sensitive to different combinations. And those are things that you cannot know ahead of time unless you really test the tumor, and you can't get it with a traditional genome-driven precision medicine approach, and that is functional precision medicine, where you really look at how the tumor is responding to the various treatments.
So under the traditional functional precision technology that you mentioned earlier, what used to take months for that tumor to grow, you've compressed in a time frame of, say, a week, and then you're able to determine which specific treatments affects that specific individual patient's tumor.
Well said.
So does this apply to most cancers? Is there one, you mentioned ovarian cancer for one. Are there specific cancers that are more amenable to this approach versus others?
Yes, I think it applies for a wide range of tumors. It applies for all solid tumors that we can get our hands on. We have done a lot with sarcomas, also in children and minors. We have also done colorectal, lung, liver mets, for example, of breast cancer patients, glioblastoma. And the interesting thing is we can test both the FDA-approved drugs. We can also test drugs that are in development.
Mm-hmm.
So if the patient is considering to go on a clinical trial, one can actually think about, well, what are the different drugs that are currently in development for which the patient would most likely to benefit from? We can test that. And then there is actually interest on looking at repurposed drugs.
Mm-hmm.
You are familiar with lovastatin and atorvastatin,
Mm-hmm.
and we have seen those being effective in sarcoma patients. We have seen disulfiram. We have seen a bunch of drugs, metformin. And if you go into the literature, there is ample of research on it, what the mechanisms are, how they affect cancer metabolism and the cancer biology. So that's actually quite intriguing. They don't always show up. I would like to say in probably 5% of cases, but that's an additional thing, not a replacement, of course, but these are additional options that we can see in our lab.
Now, what are some of the reasons behind some of the resistance some hospitals and oncologists have to this approach?
Oh, that's a very important part. And what is often not recognized is that oncologists and medicine has become overregulated,
Mm-hmm.
I would like to say. If you are in one of the NCCN cancer centers, you're expected to practice by the guidelines that you and your colleagues have set up. These are 33 cancer centers in the United States. They basically define the standard of care. And so they are encouraged to practice within those walls, and they don't carry any benefit from going beyond that. That's
Mm-hmm.
one part. The other part is it's not reimbursed by insurance at this point. So we are working on a health economic analysis to demonstrate that it can actually benefit patients, that they are not getting treated with therapy that can't be effective. So that's the second one. There is, I think those are, and then there's a question also on liability. What if I do something else?
Mm-hmm.
And so one of the things that is important to explain to oncologists is you can actually provide superior care within standard of care. I mentioned the ovarian cancer sample, when we get the tissue, the first line treatment may still be carboplatin, cisplatin, paclitaxel. But then very often tumors respond. In ovarian, you have a 75% response rate, but then you also have over 80% of patients reoccur within the same year. And then the big question is, what next?
Mm-hmm.
And we can already test this ahead of time. So you can provide superior care with better outcome within standard of care, because the standard of care is not fully developed. But for an oncologist, because the guidelines have become more and more complex,
Mm-hmm.
it adds another layer of complexity, and most oncologists are overworked and just said, I want to get through the day.
So, in terms of kind of macro level outcomes data for this functional precision oncology approach, you mentioned certain anecdotal success cases, but kind of on a more macro level, like, are there any survival benefits when contrasted to guideline-driven standard of care, perhaps? Like, what are some of the differences in terms of survival benefits and outcome benefits?
Yeah, so normally in medicine, we want randomized controlled trials.
Yeah.
That's kind of the state of the art. And ideally, even meta-analysis of randomized controlled trials. And one of the criticisms and pushback was, well, there aren't really randomized controlled trials for this functional precision medicine approach yet. And there has been a randomized controlled trial from Daniel Van Hoff in the 90s, and that failed for the reason that I said, that the treatment, it took too long to get the
Yeah.
results, and so the treatment come too late. Interestingly, and by the way, we have many things and many approvals occur for in the oncology field without RCTs, without randomized controlled trials. And an assay is actually not a drug. So requesting a randomized controlled trial for an assay is really suddenly a very high bar, which I think is politically motivated. Because if you think about ER/PR positive on breast cancer, there are no prospective trials that show that if you measure ER/PR, you have an improved outcome. That's number one. So as a caveat, number one. Number two, there is, I think last year was the first paper published that looked at recurrent glioblastoma patients. It was a company out of the Midwest, and they showed, I think, over 6 months progression-free survival and overall survival difference in the about half-year range when patients got therapy according to the assay-guided therapy as opposed to the standard of care. So that evidence is growing.
So you mentioned some of the obstacles that prevents the spread of this technology. What do you propose to overcome some of these limitations and get wider adoption to this approach?
It's very interesting. Patients need to be empowered that patients' right on over their tissue and their body is respected. Very often, especially in larger centers, there is a pushback. The patient says, I want to have the Sage Oncotest. They even may have a physician's order. And the pathology department says, well, it's against our policy. So in order to overcome this, patients need to be aware that the glamorous precision oncology approach that only uses DNA and the approach on that NCCN guidelines, NCCN cancers are taking is really a very confined approach that doesn't always consider the best possible treatment options for that individual patient. And patients often believe if they go to a NCCN cancer center, then they get the best possible care because they also have clinical trials, etc., if anything else happens, and they are on the cutting edge. The problem is because of these guidelines, even at NCCN cancer centers, the practice is really restricted to the guidelines. And so the therapy from a medical oncology perspective, the therapy you get is identical almost than you get at the NCCN cancer centers as opposed to in community practice. There is likely no difference. And there is a firewall between research and clinical care. So you may have a researcher who's working on a novel compound, but unless there is really a clinical trial on which he or she can enroll you to, he or she would not basically try to use it if other treatments have failed. And NCCN cancer centers argue that they have then the latest and greatest, but this also financially motivated because if the clinical trials are usually paid by industry very well, if you get $50,000 per patient to enroll in a clinical trial, it's very clear why you can say, well, our center is the best. You get the latest, get access to the latest innovation, but in a way, it's a academic industrial complex that is here at work, and patients are not aware of it. And so patient needs to know that they have a right to determine what will be done with their tissue when they get a biopsy or when they get a surgery, and that they actually have the right to determine and say, I want the Sage Oncotest, or I want to have a functional profiling test, because I don't want to fly blindly when it comes to subsequent therapy.
We're talking to Chris Apfel. He's a physician and clinical researcher. Today's Kevin MD article is Functional Precision Oncology, a Game Changer in Cancer Therapy. Chris, let's end with some take-home messages they want to leave with the Kevin MD audience.
Yes, the take-home message is, if you're a patient and you're diagnosed with a serious cancer, you need to be your own advocate. You need to think about what are the treatment options and cast a wide net, get a second opinion, and don't just blindly rely on a big brand. You need also a support network that helps you emotionally, that also and helps you also to look beyond the normal horizon that people normally look at if you want to have an outcome that's better than average.
Chris, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Thank you very much for having me.